Thank you, Mr. Chairman. This paper comes from the collaborative effort from two universities, University of Moscow and University of Washington. So current clinical systems that utilizes transrectal approach for treating prostate successfully produce thermal ablation of prostate tissue. However, some challenges still exist, and those are a reduced precision of the treatment due to heat diffusion and heat sinking. There is some limitation in ultrasound real-time monitoring of the treatment, and coagulative necrosis in nature is slow to resorb. So our idea is that boiling histotripsy method to mechanically ablate tissue has the potential to mitigate these challenges. In boiling histotripsy, millisecond-long pulses with high amplitude shocks are delivered to the treatment site at low duty cycle to induce vapor bubbles within each pulse, and then shock waves interact with such a vapor cavity and mechanically liquefy tissue through acoustic atomization and microfountain mechanism without thermal effect. Such a method has been already employed in a large animal porcine model to liquefy liver and kidney, as shown here. The treatment is easily visualized using B-mode ultrasound as a hyperechoic region, and after treatment, hyperechoic region is seen at the treatment side, showing that the tissue is liquefied and loses scatterers. And such a region correlates very well with gross analysis, so it shows really the vision. And histology shows liquefaction of the treatment site without thermal effect and very sharp margins of the treatment. So for prostate treatments, our simulation studies have shown that boiling histotripsy conditions can be reached even with small footprint prostate transrectal probes, not larger than those that are FDA approved for clinical HIFU devices. So while this probe is being manufactured, we wanted to show that actually we can liquefy prostate tissue. And we used tissue sample from rapid autopsy, human prostate tissue. We got them within 12 hours after death. And these samples were embedded in polyacrylamide solution, degassed for 2 hours, and then the gel was polymerized and used as a container for the tissue to sonicate. Experiments were performed using a custom-made 1.5 megahertz transducer of F number 0.75 and high-power amplifier. The treatment was monitored using two diagnostic probes. One was coaxial with the HIFU probe and operated in color Doppler mode, and another one from on the side, and it was used in beam mode. So two Verasonics engines was employed in the experiment. During the treatment, we saw echogenic spots in both beam mode and color Doppler. After the treatment, we saw this lined lesion with, it's a set of lesions with 2 millimeter spacing. So we saw hyperechogenic regions showing that the treatment was successful. And gross analysis showed liquefied volume on tissue inside a prostate tissue. So then histological analysis of the lesion showed that we have completely liquefied tissue inside the volume, and at the border there is an intermixture of homogenized tissue and some pieces of muscle and collagenous structures which are less sensitive to boiling histotripsy. But still the margins were pretty sharp. So in this study, we demonstrated the first successful application of boiling histotripsy in ex vivo human prostate under real-time ultrasound imaging. And our work is ongoing to rapidly develop a transrectal system for in vivo preclinical evaluation for BPH and cancer model. And we expect our system will be ready by the end of the year. Thank you. And this is our team.
Thank you for the presentation. I have two quick questions. One is, how long do you think it will take you to ablate 1 cc of prostate tissue in humans, in vivo? And second question is, are you at all worried about dissemination of cancer cells during this bursting process of the cancer?
For the first question, we have not yet optimized the treatment, but we would expect 1 cc would be, I don't know, in about maybe 10, 15 minutes. Or maybe we can do faster. It depends how, our pulsing protocol, we'll see. As for your second question was?
Dissemination of the tissue once you've killed it. Is it disseminated?
You mean you worry about metastasis, or you worry?
It's moving.
Look. They migrate.
Our previous results that we got in other tumors and tissue, it shows that it's complete loss of cellular structure. So, so we hope that we will not have this problem.
How fast do you see the change from the hyperechoic to the hypoechoic? What's that time interval?
Half a minute.
Half a minute.
Mm-hmm.
So you can use that then to monitor where you've been and then where
Right,
you're going
right.
to go
So
next.
you can treat and then you stop, you wait a little bit.
And then you move on.
They have to migrate those bubbles out of that and the particles.
Yeah. Mm-hmm.
Okay,
One
any?
more, quickly.
Just very quickly, quick question. How much pressure at the transducer surface for the small device you are anticipating you need to generate for your future probe, the new transducer you're fabricating?
What was the pressure in situ?
That you anticipate to generate at the transducer surface for the small.
What was the pressure at the surface of the transducer?
Yeah. For the new one you want to have.
For the new one, we consider as a technical limitation, we don't want to go over 30 watts per square centimeter. Okay. So that's in terms of intensity.
Excellent, thank you.
Mm-hmm.
Okay, I think we probably have to call time, unfortunately. This has been a great session. I want to thank all of the speakers for the great talks and look forward to more. Thank you very much.